Hey there friends, this is Dr. Russ in Portland, Oregon. Today's video is a side-lying approach to the QL, iliac crest, and thoracolumbar fascia. Gentle as always, hope you enjoy. Here's our patient comfortably side-lying, and we're giving them a little bit of a gentle, pretty superficial warm-up here. Getting my landmarks, getting a sense of the layout of things, and feeling where the restrictions and the tensions are. We think in terms of muscles, like we say, okay, the QL is here, and the gluteus medius is here, and the lumbar erectors are here. But of course, there's so much more there than just the muscles. So we use that as a shorthand to talk about it, to say, well, we worked the QL, but there's fascia, there's nerves, there's a lot of other muscles in there as well. So my landmarks here, I've got her piriformis right here and the bottom of the rib cage right here. So again, in general, lumbar erectors here, and this space is QL. Her iliac crest is here, and that's a really important landmark for so many reasons, particularly right now as an area of insertion of abdominal obliques. So the QL is there too. It's pretty deep. The insertion is going to be more on the anterior, almost inside the pelvic bowl. Whereas we're coming here, it's internal and external obliques that are all attaching here. So many people have issues with those muscles that don't show up as abdominal pain. They show up as lower back pain because of the importance of those abdominal obliques and connecting and communicating the pelvis and the rib cage. And so if there's imbalance there, there's going to be imbalance between the pelvis and the rib cage. It's usually going to show up as pain in the SI or lumbosacral area. Another really important structure and thing for us to think about is the thoracolumbar fascia. So as we go from skin right underneath there, the superficial fascia, and kind of that deeper layer is a very tendinous thoracolumbar fascia. So the whole latissimus inserts into the thoracolumbar fascia, and there's always, not always, but often going to be a very fibrous, almost like shiny silver skin section of it right here that's going to cross over the SI joint, help support and stabilize the SI joint, and connect and communicate from the upper sacrum into the lumbar spine. And that thoracolumbar fascia goes so deep that it becomes the attachment point for the deepest layer of the abdominal muscles, the transverse abdominal. So we always want to make sure that in any lower back treatment, we're freeing up the thoracolumbar fascia. So here's our landmark, right? Here's her iliac crest. And right here, as it transitions into this bulky, really, really strong thoracolumbar fascia, there's an area that's quite a lot of resistance, and it just is tight and doesn't want to move very much. So not forcefully, but gently, we're inducing movement. So I'm kind of deep with my pressure here. So obviously it's just one finger, so it's not a lot of pressure, but I'm hooking the tip of my finger anterior to that piece of fascia, and I'm giving it a stretch down toward the table and a little bit back, like toward this knee. And it's gentle. These tissues take time to remodel. And it's also good to remember that a lot of this tension is patient's nervous system decision. And yeah, right, we just kind of a lot of times just want to bring the brain's awareness to what's going on. And because I'm talking into the camera today, I'm not doing breath work with my patient, but a lot of times if I'm feeling something really stuck or just a little bit stuck, I want the patient to breathe into it and visualize it and really connect to it with their awareness, because in the end, it's their brain, their postural centers, their reticular activating system that's making the decision of how much tone to hold in these muscles and for what reasons. So that was a nice little release. It feels more mobile now. So again, this is like a QL treatment, but I haven't really even touched the QL yet. Now here I'm more in the belly of the QL. If I get a bit of a pinch, I can come at it from the front. If I want a little more room, so here's the bottom of her rib cage, here's the top of her iliac crest, there's not a ton of room. I'll ask the patient to bring this topside arm up over their head, up over the head. Yep. And now we just have a little bit more space right here. As long as the shoulder is comfortable with that, we can do that. If patient having a shoulder problem, we can get the same thing with the arm a little bit more forward of their head. So again, this is a gentle QL stretch. It's one thumb on the edge of the QL. It's my fingertips. See how I'm kind of inducing a rocking toward me? So it's not an isolated movement to this muscle, remembering that her body is a cylinder and we're just working on one layer of the cylinder. We want things to move in an integrated way. We're not trying to get isolated movement just to one segment or one joint or one tissue. So getting this rocking of her whole body. We can also induce movement between the pelvis and the rib cage. So she's balanced really nicely on the table. Your patients generally will find a pretty balanced position. So this pulling, see I'm rocking her whole body with my right hand on her lower rib cage. There's no grab, there's no tickle. It's just tiny little bit of force. And then with my other hand, I provide a little counter pressure. And this can be a very nourishing little movement for the lumbar discs, nourishing movement for the lumbar facets, and also give us a sense of how well these two structures are moving in relation to each other. So that's a nice, easy side-lying approach. We released the thoracolumbar fascia, a little bit of QL, and did some nice proactive mobilization of our lumbar spine. Thank you.